Hi, this is Brian Kim. I want to share with you this case of a patient who was referred to me for an opacified IOL. Actually, this patient had cataract surgery 16 years ago. This is a post-RK patient, and the patient has an in-the-bag Technis Z9002 silicone lens. And this patient, because he had RK, ended up with a hyperopic refractive miss. Remember, back in those days, we didn't have the RK formulas we have now. And so although we're much better at targeting and getting to emmetropia with the post-RK patient, back then we didn't. And so this patient ended up quite a bit hyperopic, and the patient has a low-powered star silicone 3-piece lens in the sulcus as well. Now the problem is I don't know which IOL is opacified. And so you're going to see as I remove the lenses, you're going to see the bag is really not very stable after 16 years of surgery. And I'm going to do my Yamane technique using the AR40 lens. And you're going to see that it's decentered. I'm going to share with you why mechanistically the lens decentered and how I'm going to fix it. And so you can see this is the lens. There's two lenses here. You can see the brown haptics as well as the blue haptics. I make my incision first on the right side and then the left side, making sure I'm parallel to iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. This is intracameral epinephrine and then some dispersive viscoelastic. And this is a 3mm blade. I always make a 3mm incision when I'm doing these lens exchanges, especially when I know I'm going to place a 3-piece lens. And this is a Lester hook. I'm going to go ahead and just dial that star 3-piece silicone lens into the sulcus. Again, you know that this is that star lens because it has those brown polyimide haptics. Those brown polyimide haptics are very brittle, so you don't want to grab them here. So I dial both haptics into the anterior chamber, and these are the micro scissors and forceps. I'm going to grab with the serrated forceps and then cut all the way through. You can see it cuts rather easily. Why? Because this is only a 3 diopter powered lens, a very thin lens. I'm going to grab the edge of the optic, the cut edge of the optic on the right side. I'm grabbing it by the cut edge because this will allow the haptic to collapse on itself, just like that. And then I'm going to grab the other piece, and you're going to see I'm twirling the lens clockwise so that I can grab the cut edge of the lens on the other side. And I like to grab the cut edge again in the same manner because it allows the haptic to collapse on itself. Now if you look closely, the surgeon did a YAG capsulotomy right here. Despite the YAG capsulotomy, there is opacification of the lens. So this is when he realized this is not a PCO, this is an opacified lens. And so this is the prototype IOL capsule dissector that I'm working on with Epsilon. I'm able to get underneath the capsule rather easily, and I have it mounted on some viscoelastic, some dispersive viscoelastic. I'm getting underneath the rhexis edge, and I'm pushing dispersive viscoelastic to separate the anterior and posterior capsules. And I'm going around circumferentially 360 degrees. The hardest part, of course, will be where the optic-haptic junction is and the haptic into the capsule fornix. The haptic may be fused to the capsular bag. So you can see I'm going around all the way 360 degrees. And here I'm just trying to dial the lens up out of the bag, but you can see it's rather challenging to do with the Lester. I am not showing you how much I had to edit because I was trying to dial it up and it just was really stuck. So I'm going to use a two-handed technique. I'm going to lift the edge of the optic here with the Lester, grab the edge of the optic with the serrated IOL holders, and then I'm going to push the capsule off the right side haptic, as you can see here, using the Lester. So very carefully trying to free that haptic. You can see that it is tethered fairly strongly to the bag. I have to re-grip with the forceps as I try to tease that haptic off the capsular bag, and then try to do the same thing on the left side haptic, pulling the optic-haptic junction and trying to dial that haptic into the anterior chamber. Okay, so that trailing haptic is now fully in the anterior chamber, and I'm trying to get that other haptic into the anterior chamber. I'm going to get around it, tuck it, and I'm able to pop it into the anterior chamber. I switch the Lester to the IOL scissors, and I'm cutting. Again, this is a Technis Z9002 silicone lens. These silicone lenses are rather difficult to grip. If you have smooth forceps, it'll just slip off. So you do need to have a serrated forceps. So I'm switching the scissor to these forceps. Now these are smooth ones, but that's okay. I'm going to grasp the haptic. I'm inching over towards the tip using a two-handed technique, shielding the cornea with the other forceps. You see here, I'm going to try to grab the edge, but you can see it doesn't grab. Again, that's because it's a smooth forceps. Switching forceps now, so the serrated forceps are in my right hand. Grabbing the cut edge here, and as I do this, I'm able to pop it out. And then now I'm going to grab the other lens piece. I thought about grabbing the optic, but then I changed my mind, and I'm going to go ahead and grab the haptic. So I grab the haptic, slide it out, rotating it, grabbing the cut edge, and popping it out. So now I have both lenses out of the eye. This is a 20 gauge infusion cannula, and then I'm going to do a limbal vitrectomy. You can see that there is some vitreous to the wound here. Not a whole lot, but just a little bit. Carefully doing vitrectomy. You can see there's a large Sommering's ring right there on the right side. It's not really going anywhere, so I'll just leave that alone. I'm getting a sense that the bag is not really very stable, especially in the subincisional area. I don't really see a distinct rhexis edge. I'm not quite sure I can do a sulcus lens with optic capture in this situation. Again, this surgery was 16 years ago. I am not really confident of the status of the bag. And so because I know how to do the Yamane technique, it really doesn't make sense in my mind to try and test it and take a chance. So I decided to go ahead and hydrate my incisions, firm up the globe, and I'm going to place my pars plana trocar, turning the eye with the cotton tip, indenting the sclera about 3.5 to 4 millimeters back, tunneling 3 millimeters towards that indentation, tunnel, and then I dive down perpendicular. And by doing it this way, I'm able to achieve a self-sealing sclerotomy, making my incision contralateral limbal incision to externalize a leading haptic for my modified Yamane technique, my Kim modified Yamane technique. By externalizing leading haptic, I'm able to access the trailing haptic with a lot of confidence and with a lot of ease without causing any unnatural manipulation of the haptics, which is very important for this AR40 lens. So I mark the tip of a 27 gauge cannula, and I'm able to ink the limbus on the right side and then the left side 180 degrees apart. And this is a fixed caliper from Epsilon. I have no financial interests. I'm going to indent 2.5 millimeters posterior to that mark in radial fashion, and then 2 millimeters adjacent. And I call that the backwards L configuration on the right side. You want to make sure you remove all the fluid. Weck cells are very important here, and then you're going to ink the indentation. I do the same technique on the other side, the left side, making sure it's nice and dry. Again, indenting 2.5 millimeters posterior to the limbal mark in radial fashion, and then 2 millimeters adjacent. And with the left side, I like to call this the backward 7 configuration. Again, I indent, dry off really well, and then using that inked 27 gauge cannula, inking the indentation. This is my incision for the AC maintainer. This is a 22 gauge thin-walled AC maintainer by Epsilon. Again, no financial interests. Taping it down with steri-strips. And this is my right side needle. I'm bending the needle 9 millimeters from the tip, and I'm going to angle it about 70 to 80 degrees with the bevel facing towards the main incision. This is the left side. Needle is going to be bent towards the contralateral limbal incision, bending the needle at the hub. And this is the 25 gauge needle to externalize the leading haptic, and the bevel is going to be facing towards the right. This is a cartridge. Fill the cartridge with cohesive viscoelastic, carefully placing the AR40 lens on the cartridge, making sure the edges of the optic are seated down before I bring the wings together. I bend the wings together, make sure the optic is seated down, push down on the optic so it turns backwards concavely, making sure the leading haptic comes through straight through the barrel, and the trailing haptic comes outside the back end. Sliding it into the injector, making sure the trailing haptic is above the edge of the barrel. As you can see here, it's above, pushing the plunger and advancing the lens. So now I'm ready to go. The 25 gauge needle is placed to the contralateral limbal incision. The bevel is facing to the right. I'm placing the Sensor AR40 lens now, placing it so that the bevel is facing to the left. My surgical assistant advances the lens. I'm going to dock the haptic on the bevel of the needle. I lost the haptic on the needle, and that's because I'm not completely well aligned. So I go ahead and try again. Go ahead and advance. Withdraw the needle, and the haptic goes straight out. This passive docking technique is very important because you don't want to disturb and crimp the tip of that haptic since it needs to go inside the 30 gauge thin-walled needle. Pushing dispersive viscoelastic to protect the corneal endothelium and push the optic back. And here we go. This is the right side needle. But before I do that, I'm going to pull some of that leading haptic outside the eye first. You want to pull it out some more so you're pushing the optic away, which gives you better access to that trailing haptic. You can see here, because I'm sitting temporally, I have to modify my technique a little bit. I'm turning the eye a little bit to the left. I stab the conjunctiva sclera at the first mark. I stay nice and shallow. I tunnel 2 millimeters. I make sure I'm in the scleral tissue, 2 millimeters, and then I dive down. Very important during the tunneling that the eye is firm and I have infusion on when I'm tunneling the needle through the sclera. Now, once I have the needle in, you can see here there's some capsule there. I want to make sure I'm actually over the capsule. I make sure that the needle pierces above the peripheral capsule in that area. You saw that I grabbed the leading haptic, pushed the optic away some more, and then very carefully grasping the trailing haptic about 2 to 3 millimeters from the tip, docking the haptic on the bevel of the needle, aligning the haptic to the needle, and it goes right in. Very important that you direct the needle towards the haptic, not the other way around. And it's very important to be able to align the haptic towards the needle with the bevel facing in parallel fashion in order to be able to dock it easily and effectively. Easier said than done if you're not used to doing those maneuvers. Disengage the needle from the syringe, internalize the leading haptic with microforceps, grabbing the contralateral limbal incision with forceps. This is the thing. I'm trying to keep the eye in the neutral position, and this is the new technique I've been doing, but I've had some decentrations, and I'll show you why. As I puncture through the needle from the first mark to the second mark, I'm inadvertently going more anterior towards the limbus. And because I'm turning prematurely, I'm not diving down towards the nerve. And because I'm not diving down towards the nerve, and I'm turning a little bit prematurely, you're going to see that the needle is actually more anterior. It's kind of emerging from the sclera more anterior towards the limbus. And because of that, when I'm done with the Yamane technique and I see where I am, my lens is decentered. And so I'm just letting you know, here again, I have my needle facing the haptic. This is the best technique. Make sure the needle is facing the haptic. Don't distort the haptic and twist it, because the needle you can manipulate, but the haptic you can't. I dock the haptic on the bevel of the needle, and it goes right in without any difficulty with either side here. I withdraw the needle a little bit on both sides. I make sure I pull the left side all the way out, pulling down towards me, grabbing the haptic with forceps to make sure I stabilize it. I'm drying the surface of the eye so that the haptic is nice and dry before I cauterize it. So here we go. I cauterize the haptic tip, but you can see it's sitting a little bit up, almost like a flagpole sign. And you can see that the trajectory of that left side haptic is more anterior. It's not at the right angle as I normally do. So I go ahead and pull the right side needle, pulling it away from me, making sure that I grasp the haptic as it comes out, cauterize the tip. And so just observe here, the haptics are not fully aligned. I'm always very confident with my right side haptic because that's the first one that I do. And I have very good control because I have that trocar cannula. As you can see, the lens is not perfectly aligned, and it's because of what I said. So I'm pulling the left side haptic up. I amputate the tip with forceps. I grasp the leading haptic with microforceps, pull it through the eye, and then reposit it into the angle. I'm grasping the contralateral limbal incision with microforceps, turn on infusion, and I'm going to start again. So this is very important. You can see the difference. I'm stabbing, I'm staying shallow, stabbing the conjunctiva sclera, tunneling 2 millimeters. But look, I'm going to be intentional about diving towards the nerve. You saw that? Very subtle, but so important. I'm diving towards the nerve. I'm making sure I'm parallel to the limbus. I'm at right angles instead of tunneling towards the limbus, which I did the first time. And because I was shallow, the lens was decentered. I made sure I'm more posterior this time, tunneling 2 millimeters and then diving towards the nerve. I had a more posterior trajectory with my needle, and then I rotated it into view. I have the needle, again, twisting it into the direction of the haptic. Remember, you want to align the needle to the haptic, not the other way around. And because of that, I'm able to dock the haptic on the bevel of the needle, and it goes right in. I didn't have to worry about cutting the haptic at an angle or any of that kind of stuff. It doesn't matter. I just cut it flush, and it went right in without any trouble. And so all of this stuff about the haptic not fitting in the needle, again, has not been my experience. I cauterize the tip, I push the tip in, and look, perfectly centered lens. And so I'm confident that these few cases of decentration that I've had have to do with me modifying my technique because I'm grasping the contralateral limbal incision. I'm not allowing my needle trajectory to go the way it used to. When I used to do my technique, I let the eye turn from me. It naturally caused the needle to go more posterior. So because I've modified my technique, my needle ended up going more anterior, causing decentration. So that's my learning point for myself. I need to make sure I turn and make sure that needle goes down towards the optic nerve. I'm doing a little bit of vitrectomy. You can see there is a Summering's ring. Unfortunately, the video got cut off, but I actually removed this large Summering's ring very carefully using a Lester forceps and then using infusion to burp the Summering's ring out. And this is a suture, the tenonalan suture to close my main incision. And this is a surgical PI. This is a low flow setting in order to get a nice discrete PI and to make this PI on the temporal side. Don't go all the way to the angle. You don't want to eat the ciliary body when you make the PI. This helps reduce any risk for iris trampolining and reverse pupillary block postoperatively. So essentially, this is the end of the case. So let's summarize here. This patient had 2 lenses, 2 silicone lenses. In the bag lens was the one that actually opacified. I was able to carefully remove each piece by cutting each lens in half. The bag was rather unstable, so I switched to my Yamane technique. The only downside with doing it this way is I have my incision, my main incision temporal. I normally like to make it super temporal, so it got in my way when I had to make my marks for my scleral needle placement. You can see I'm abutting into the lid tissue. This does not provide optimal exposure. So this again shows proper planning is very important. In retrospect, I should have made my main incision in the supratemporal area, assuming that I had to go with the Yamane. But instead I thought, oh, I'll probably be able to put the lens in the sulcus and optic capture it. And because I had a more laissez-faire attitude about it, that's what got me. And if you're not mindful and proactive and thinking ahead of time, you have to think kind of worst case scenarios and be prepared for worst case scenarios. That's the only thing I would have done differently. Again, with my Yamane technique, placing the leading haptic outside the eye with a passive 25 gauge needle docking technique. So I'm very gentle on these very delicate PMMA haptics of the AR40 lens. I'm able to very easily execute the placement of the haptics to the needles. Why? Because I have a lot of practice with it. I'm very gentle. I have very thoughtful techniques. I'm making sure the bevel is facing towards the haptic. In the case of the right side needle, the bevel is facing towards the main incision. The left side needle is facing towards the contralateral limbal incision. And why is that? Because the curve of the haptic is facing in those directions. And so I'm able to land the haptic on the bevel just like an airplane lands on a landing pad. I'm able to land the haptic on the needle. And all I have to do is make sure I'm aligning properly. And as long as I align it properly, I'm able to dock it, flatten it out, and straight and slide it in. And it goes in very easily. At least in this case, it went very easily. And again, I had a decentration. Why? My technique on the right side hasn't changed. But with the left side, since I like to grasp the contralateral limbal incision to minimize any excursion of the eye, this has changed my technique. Because I was passing the left side needle in the same way, I didn't modify that technique, and so the needle was emerging more anterior. And so instead of tunneling perpendicular, it was tunneling towards the limbus a little bit, just a little bit, not a lot, enough that it caused the needle to emerge out of the sclera more anterior towards the limbus, therefore causing a decentration. So you saw I was able to pull the haptic back up, cut the bulb, pull the haptic back into the eye and start over. But the second time I tunneled 2 millimeters, but I dove towards the optic nerve. I made sure I dove straight up and down and perpendicular, and then I was able to turn that needle to face the haptic, slide it in, and execute it in a much more symmetric manner. You saw perfect alignment and symmetry of the lens after I got done with rethreading it. And remember, people get worried about threading the AR40 haptics into the 30 gauge thin wall needle. People worry about, oh, it's going to get stuck, it's not going to fit. People talk about cutting the haptic on an angle. This one I just cut at right angles. It's not a big deal. And I was able to thread it without any difficulty. But again, you have to pay attention to each of these steps. And even though I've done hundreds of these cases, and you can see even just making a slight adjustment to my technique has had a ripple effect. And so I've had a few of these decentrations. And so therefore, in future cases, I'm going to be much more mindful of diving towards the nerve. And I share these cases with you because by troubleshooting it for me, hopefully it'll teach you that all of these little subtle maneuvers are so important. And if you don't pay attention to the details, that's when things can go sideways. And you might wonder and scratch your head, what happened in this case? And it's not because something magical happened. It's because you're not paying attention to each of these steps. By really, really focusing on each of these steps, you can achieve really good, consistent execution, not just from a surgical complication perspective and minimizing risks, but also achieving excellent refractive results. This patient, despite the dilated eye, post-op day 1, he had achieved 20/50 vision uncorrected in this RKI that had surgery 16 years ago. So I hope this was helpful to you, and I thank you for your attention.